Okay, ladies and gentlemen, may I have your attention, please? Welcome to the American Foreign Service Association. My name is Ian Houston. I'm the Executive Director at AFSA. And I normally don't have that as part of my voice, but we like to have the sound system in here, although you could probably hear me without this. But we do that because we're recording this event, and we like to keep it for many generations to come. And perhaps, Judy, that's in 10 years we'll go back and we'll watch this tape and we'll say, she had it right. She had it right on
I certainly hope so.
This is a very, very important issue. Thank you for your attendance here as we discuss the future of Medicare and various perspectives on a very complicated issue. We welcome you here to this, what we think of as a series, a formal series that AFSA has created to address federal benefits issues, which are very important to AFSA members, but we also recognize that AFSA as an organization plays a role in reaching out to the larger community of individuals in the Foreign Service, of course, but that goes beyond. And so we as an organization take a real interest in addressing the issues that both impact our members, but also their families, their loved ones, and our neighbors. And being in Washington, this is an incredibly important issue for many. Today we have Dr. Judy Fader. You have her bio sheet on your chair, so I won't get into too much detail here because there's a lot to say about her. She most certainly is a nationally recognized leader in health policy, and today is going to address a very timely issue of Medicare, an issue that many of you have been thinking about as the country has been addressing a very complex issue. What we can certainly agree as this talk is the future of Medicare. I think we can all agree that there is indeed a future of Medicare. The future is one that is not clear, and so therefore we need experts to come to the table to help us understand this issue. Judy is a widely published scholar. She has started her health policy research at Brookings Institution, that continued at the Urban Institute, and since 1984 has really flourished at Georgetown University, where she is a professor of public policy. From 1999 to 2008, she also served as the Dean of the Georgetown Public Policy Institute. Judy has also been active in promoting effective health reform in various governmental capacities, and as a member of many professional associations, such as, for example, the Institute of Medicine, the National Academy of Public Administration, and the Kaiser Commission on Medicaid and the Uninsured. Now, after her presentation here, we will have some questions, of course, and comments, I think, honestly, in such an intimate gathering here. And Judy has agreed certainly to engage with the audience in answering your questions and reacting to your comments. So I think what we'll do is we'll have Judy open up and offer her thoughts, and then we'll carve out that time for a question and comment session. And I'll remind everyone that this is being recorded, and we'd like to have all ask their questions here at the microphone so that we can properly record it and just have it well choreographed. And we really appreciate you being here and look forward to a very nice conversation. Judy, thank you very much.
Well, thank you very much. It's a pleasure to be with you. Give me applause before I even start. I'll take it. And we'll see how it compares at the end. That would be a good thing. Bonnie said to me that as I arrived today that it's such a timely topic, and it's she who gets the credit for the timely topic. This is what I talk about all the time, so I'm glad that you invited me to talk about it today. Medicare is clearly front and center in the presidential campaign, which is not surprising given the importance of Medicare to the federal budget and to seniors, people with disabilities, and their families, and also because of the very different perspectives programs of the Democratic and the Republican parties. And I imagine you might find yourself, except when you're, for the possible exception when you're listening to Bill Clinton, you might find yourself confused about lots that goes on in healthcare today. So what I thought that I would do, though I would state from the outset, I know Bill Clinton, and I know Bill Clinton. I would give you my perspective on the current state of Medicare, its strengths and the issues and the path forward. But I really do want to engage in conversation with you and hear your questions and concerns. And if some of them veer into other areas, whether it be Medicaid and long-term care, or the Affordable Care Act and health insurance and health care costs for everybody, that's fair game as well. So we'll do what we can, but start with Medicare. So first and foremost, I think it's important when we talk about the Medicare program to address the question of whether or not the program works. And I want to give you a resounding yes that the program works. The record tells us that Medicare works better than private health insurance in securing affordable health care for seniors and for disabled beneficiaries. Now, let's start at the outset by recognizing that Medicare is not, by the standards of health insurance today, overly generous. Its benefits were largely designed, or are largely as they were designed in 1965, reflected what private health insurance looked like in 1965, if I said differently. The biggest gap now that we have expanded coverage for prescription drugs, and that was further expanded, that protection improved in the Affordable Care Act. There are two big holes in Medicare coverage. One different from private insurance, one not different. What Medicare beneficiaries don't have that federal employees have, and almost anybody with employer-sponsored health insurance has, is a cap on out-of-pocket spending. So protection against catastrophic expenditures. Medicare doesn't have that. And that is a primary reason, now that prescription drugs can be covered in other ways, that people buy supplementary Medigap coverage to make sure that they are whole, and they need to, because people need to be protected against catastrophic expenditures. The hole that I mentioned that Medicare does not cover, but neither does private health insurance, is long-term care costs. Medicare covers some nursing home care and some care at home after a stay in, in some cases after a stay in the hospital, some cases without a stay in the hospital. But for someone who needs long-term personal assistance with basic tasks of daily living, Medicare doesn't cover that, and neither does most private health insurance. What we rely on to protect us against, in those circumstances, is overwhelmingly help from our family and friends. And I don't help from our family and friends, and when we exhaust our resources, we rely on the Medicaid program. And as Bill Clinton did explain, a lot of Medicaid spending, about a third of Medicaid spending, goes to long-term care. So that's a different topic, but you should know that the program doesn't cover that. So it gives good, strong coverage. Now let me tell you what it does when you think about it relative to private insurance. It is much more effective than private insurance in terms of limiting what it pays for care, or let me say it is more effective than private insurance in limiting what it pays for care, and it is much more effective when it comes to pooling risk, to bringing together people regardless of health status into one pool with one purchaser, so that we don't have a discrimination in health insurance plans based on health status. So first, in terms of its purchasing power, Medicare buys for, there are now about a quarter of beneficiaries in private health plans, and we can talk more if you'd like to about how that came about. They are not, for the most part, less costly. They are more costly than basic Medicare. They've essentially been overpaid in order to get them to participate in the program that began in earnest in about 2003. And they use those extra payments to fill in some of these holes that I'm talking about in Medicare benefits. But they are not more efficient than than Medicare, basic Medicare. But let's look at what Medicare, for the 75% of beneficiaries, Medicare buys on their behalf. And because it has so much purchasing power, it is essentially setting payment rates for all seniors and people with disabilities, or 75%, who are on that program. It has enormous market power with hospitals and doctors. It's just a hell of a big purchaser. And it doesn't say that it negotiates, it's therefore able to negotiate good rates, is an understatement. It sets the rates. And providers accept those rates because most providers, not all, but most providers, can't afford not to take Medicare beneficiaries. Older people, not surprisingly, use more health care than younger people. Most providers need us in order to have a decent income. So Medicare has tremendous market power. It means that it pays doctors and hospitals 20 to 30% less than private insurance, and its growth rates have historically been lower on an annual basis than the growth rates of private insurance premiums. Not a lot lower historically, but lower. And so that's it is important to recognize everybody's buying in the same healthcare market. So there's some relationship in terms of the private sector and the public sector. You get too far apart and you run into access problems. But it's important to remember that Medicare growth is slower and rates are lower than private insurers. Second major feature is pooling risk. We know in the discussions around the Affordable Care Act that a major problem in the health insurance market for people who don't get coverage through their jobs is the cherry picking of the healthy, or cherry picking of people when they're healthy, and avoidance of people when they're sick. That's how insurers do the best. It's also how we as individuals, we get a lower premium if we're insured with healthy people and not sick people. That's kind of, we collude on that basis. But what that means is, if there's all that kind of cherry picking, is that insurance is not doing what it's supposed to do, which is to spread the risk, to have us pay premiums all the time, regardless of our health care needs, so come from everybody, so that the minority among us who have extensive health care needs can we can devote the resources to that population. Any market in which there are multiple insurers competing faces the challenge that there will be competition based on health status. And even in private plans and Medicare Advantage plans, we find powerful evidence of that kind of risk selection. And that means that insurance is not functioning to fully pool risk, because if you're in a plan with a sicker group, you're going to pay more. And that's a major problem. It's a problem that traditional Medicare doesn't have. All in one big pool, all purchasing together, and all spreading risk. Now, the second question I want to address is whether Medicare costs are a problem. And the answer is a resounding yes, but. Okay, so first, to be really clear about why everybody from a budget perspective is so focused on Medicare. Medicare is currently at about 13% of the federal budget. We spend another 7% roughly of the federal budget on the federal share of Medicaid, which, as I said earlier, covers long-term care and fills in gaps for Medicare beneficiaries, in addition to covering the costs for the younger Medicaid beneficiaries, the poor people who qualify for Medicaid. So, big part of the federal budget. And more important, or as important as how big it is that it's growing as a share of the federal budget. Medicare and Medicaid and Social Security are entitlements, which means technically that spending on those programs are not subject to annual appropriations. They are mandatory spending. And their spending is determined by how many people show up and what kind of benefits they're entitled to that prescribed by the program in all of those programs, and the costs of those benefits. Now, we don't have that kind of service cost issue with Social Security. That's a cash payment eligibility. But with Medicare and Medicaid, how much you are spending on the program depends on how many people show up and how much health care they actually use, and what the program is paying for that care. So you want to think about the cost of Medicare as the product of two elements. One is the number of beneficiaries, and the other is the cost per beneficiary. Or I usually say it's cuter the other way. It's per capita costs and the number of capitas, okay? So that's the way to think about total Medicare costs. Now let me start with how Medicare fares, and I've already signaled some of that, in terms of its per capita costs, which really that's the healthcare costs. And now healthcare is expensive, and even though I've already told you that Medicare is a more effective purchaser than the private sector, we in this nation are spending too much for health care, much more than other nations, much more than either our higher incomes would suggest, and much more than is justified by any evidence of the relationship between spending and quality of care. So that, I'll come back to that again. But again, Medicare, though it needs to do a better job, it is doing a better job than the private sector, and because of the Affordable Care Act, it is constraining what it pays providers much more aggressively than it has in the past. You've heard Governor Romney attack and Congressman Ryan, I'm laughing well, for reasons that will be obvious in a moment, attack the Obama administration for, what do they call it, raping the trust fund, or undermine, stealing from the Medicare trust fund to pay for the Affordable Care Act. That $716 billion that's been talked about in savings in Medicare are reductions in excessive payments to both providers and to health plans, money that we don't need to spend to get access to care. So they are savings that make the program more efficient, actually extend the life of the trust fund momentarily. The trust fund is under Part A, the hospital part of Medicare, which are paid for through our payroll taxes, not through premiums that beneficiaries pay, but paid for the payroll taxes of the working population. Those they become a trust fund. They buy treasury bonds, and they are used to finance the program. That trust fund, the revenue from payroll taxes, is what goes to support Medicare, and the payroll tax revenue, I'm digressing a little, are you following me? I'm okay? All right. The trust fund, that trust fund is currently scheduled to be inadequate to pay out all the benefits under Part A in 2024. We've had many times that it's supposed to be inadequate. And it's because the payroll tax rate has not been, or the revenues have not been rising as fast as healthcare costs have been rising. Because of the Affordable Care Act, and overwhelmingly because of the constraints on growth in provider payments and overpayments to the private health plans in Medicare, we got to 2024 without the Affordable Care Act. The date of exhaustion of the trust fund is 2016. So what happened in the Affordable Care Act was that the growth in payments to providers were significantly constrained, a real savings to the program, extending the adequacy of payroll tax revenues coming in to support the benefits in the program. Doesn't mean we don't need to do more on cost containment, doesn't mean 2024 is as long away as we would like, but it's improved the status of the program. Nothing about stealing from Medicare beneficiaries. It's all coming from reductions in growth rates in payments to providers. As a result, Medicare per capita costs are now projected to grow roughly at the rate of the growth in the economy, which is really quite extraordinary. We have historically been much higher than that. It is a constraint. We have, as yet, no evidence of access problems, so I'm sure that's a matter of concern, whether we're being paid adequately, but essentially, Medicare beneficiaries are able, as I said before, to get access to care at constrained rates because providers need the revenue. So Medicare is quite constrained on the per capita side. what the growth that is a little bit faster than the economy is total growth of Medicare. And that is the combination of the per capita growth and the number of capitas. And this should be no surprise to everybody. I have been talking about the baby booming generation arriving on Medicare for my entire career. So that, it looked like it was a long time from now, and son of a gun, here we are. And I would say personally, I think that's a very good thing. So I'm happy and proud to be alive to be a Medicare beneficiary. That's a good thing. And what that means, and again is no surprise, is that we've got 1.5 million beneficiaries added to the Medicare rolls every year for roughly the next 20 plus years as the baby boom generation comes on to Medicare. And for the first time, it's not the per capita spending that seems to be high and out of whack. It's growing where people want it to grow at about GDP, and we'll have to work to hold it there, but that's where it is. It's the growth in the capitas. And so it is a perspective that is often lost because there is so much focus on needing to control spending, that there is an ignoring of the fact that you have a large population that's coming onto the program. And while we need to do better in controlling, as well as we can in controlling per capita spending, lest you're going to walk away from this obligation, what we've really got now is lots of people who are counting on the program, and on a program, let me go back and remind you, that program that works. So, where do I want to go from there? Now, so that's the picture of what's going on with the cost. If you want to do something about cost, you have to do the best you can on the per capita side. But I would argue that in order to protect people, you want to keep this insurance system that works. So what do President Obama and Governor Romney propose for the future? Well, Governor Romney has really bought into, for the most part, the plan that was put forward and for which he got a lot of credit, God knows why, Path to Prosperity of Congressman Paul Ryan. And the premise of that plan when it comes to Medicare is that the way to control Medicare, future Medicare cost growth, is to transform Medicare from a program that guarantees people who qualify that their services will be covered, a given set of services, and government will pay for those services. It is that instead of having that kind of program, they ought to change it to that's called a defined benefit program, to a defined contribution program, in which people will be given, Medicare beneficiaries will be given vouchers set at a certain level, and with growth rate in these proposals typically constrained to a particular level. And with those vouchers, people will go and shop for private health insurance. And the premise of that arrangement is that having private health insurance plans competing for the enrollment of Medicare beneficiaries, the argument is they will compete by becoming more efficient, and that will lower health care costs. All right, couple of problems with that. Number one, we've never seen it. It doesn't happen. And you can talk about federal employees, you can talk about Medicare Advantage, doesn't happen. The competition, this kind of competition has not effectively controlled costs. As I said to you earlier, what we find with competition, even in the regulated Medicare program, is that competition, it works to divvy up risks, health risk, instead of pulling it together. So we see a lot of cherry picking and sick people concentrated and paying more in some plans than others, and people having to pay more for care based on their health status. Precisely what we want to get away from, what insurance and what Medicare achieves. What we also know from experience is that if we're looking at private health insurance as any kind of model relative to Medicare in terms of getting effective bargains from providers, remember I said at the outset, Medicare is a big mother purchaser. Why would you want to divvy up all that purchasing power and make it an exchange between us as individuals and insurance companies who, for the most part, haven't done squat to control healthcare costs? So you would think, if you're advocating this change, that you would have some evidence that it is indeed superior to Medicare, or that Medicare is failing. Medicare is not failing relative to the private sector, and the market would take us only in the wrong direction. Now, everybody knows that it's a gamble, since there is no evidence that this kind of market would contain healthcare costs. And so the Congressional Budget Office, which we look at as the scorekeeper on proposals that tell us whether it's going to reduce the deficit or not, they will not score competition as achieving significant results in cost containment. So that any proposal, and Ryan's initial proposal was the strongest on this, he's backed off it some, but any proposal that actually wants to be scored as reducing costs, any voucher proposal that wants to be scored, has got to set an arbitrary limit on the growth in the voucher. Now, when Ryan started out, he had that voucher growing, if I remember correctly, on a per capita basis at GDP plus 1 percentage point. Medicare is already growing slower than that, more slowly. So that if he wants to pull that, if he wants to get savings out of his voucher, he's going to have to pull it down below where Medicare is growing. And when he does that, if we have no evidence that the competition is going to reduce the cost, what's the result? It essentially means that the amount that we're getting to shop with the federal government is constrained. So yes, federal spending will be held in check, but who will bear the burden of the difference in the costs? That would be us. That would be beneficiaries. And we're not talking either now or in the future. I think that we are a relatively fortunate group among the elderly population in terms of our income and our resources. The median income for seniors is about $26,000. And they are not drowning in assets. I mean, that is a misapprehension that we're all a bunch of greedy geezers. So it's not that, it is, when you look into the future, it's not that we have reason to believe that seniors can afford to deal with this extra, or that as shoppers, they're going to be able to control the extra from going up. It's simply a shift in burden from the taxpayer and the program to the beneficiary, and one that undermines insurance protection. Now, what would President Obama do about the future of Medicare? Well, I already told you that he's taken that the Affordable Care Act made this $716 billion reductions in excess payments to providers and to Medicare Advantage plans that extends the life of trust fund. That's what's brought the growth rate down. In addition, and we can talk more about it if you have questions about it, the law established, although it's not been, has not moved forward, what's called an Independent Payment Advisory Board. That is, it's a board of experts appointed by the President and approved by the Congress, who, if the Medicare growth rate exceeds the amount that's already projected, again, it's doing better than these ceilings. If it exceeds it, this body is required to make recommendations to bring that rate down. Their activities are limited to, or the place where they can make a difference is limited to rules affecting the way in which providers get paid. They can't cut benefits. It says that in the law, so it's all about, again, being more aggressive on provider payments. And the reason this board was established was to overcome, it's given fast-track authority in the Congress. So Congress, it's modeled on, not exactly, but quite similar to BRAC, the Base Closing Commission, where Congress has very little room. It either goes up or down, or provides savings in another way, to kind of to overcome what is a long-standing bipartisan problem, which is that every member of Congress is very responsive to the providers in their district. Even some of the strongest budget hawks who say Medicare spends too much and we really need to do something about it but not in my district, paying my hospitals more. So that has been a continuing, and will be, with or without a commission, a continuing problem in keeping Medicare costs and provider rates under control. One could argue that's democracy at work, but this kind of shifts the burden. They would have to work harder to overcome it than they would otherwise. It changes the rules. So there's that kind of lid in Medicare. Now, all of that's what the Congressional Budget Office scored as producing savings in the Affordable Care Act. So we are most definitely spending less. The rates are lower. But there's another part of what's been done in the Affordable Care Act that gives people great hope for the future. That is a process of experimentation in changing the way in which we pay for health care. And note, I'm talking all about how the government pays for health care, and it's using it as a model for how everybody pays for health care. That's quite different from setting up consumer shopping. Okay, so I'm looking at that government controlling and more effectively paying providers. And the shift that is being explored is the following. Public and private sector alike, the payment system that has grown up in this country, quite different from other countries in which all of spending may be under a government rubric. We do not have a budget for health care. Private and public payers pay rates to providers. And those rates reward providers for the more services they give, and the more expensive they are, the more money they make. Okay? So the idea is that that's not so good. We've got lots of evidence that more health care is not better. I'm sure we're all very conscious of staying the hell out of a hospital whenever you can, because it's such a dangerous place to be. I think that we are aware of the challenges in terms of dealing with multiple providers who don't talk to each other, of people going into the hospital, out of the hospital, bouncing back in. The objective is to move to a system in which providers take greater responsibility for managing, for coordinating all the services that a patient needs, and are rewarded for doing that efficiently and for satisfying quality standards. Now, I can describe it to you perfectly plainly. It makes total sense. But we are on the ground floor of doing this well. Nobody's got magic, and it is changing the entire healthcare system. Many years ago, Medicare moved more into this direction when the program changed the way it paid hospitals, and the private sector tends to follow what Medicare does. So although the law authorizes pilots in the Medicare program, the hope and the way in which the administration is implementing the law is to engage the private sector wherever possible in parallel efforts. And the new authorities in the law, Secretary has the authority when she's supposed to evaluate what the effect of a pilot is, of a new payment approach is on spending on quality, and if the evidence is that it works, she can then expand it. So she can't wipe out the rest of the system, but she can move this forward. And it's my view what you've got in the background is this Independent Payment Advisory Board that, if in fact more is needed, that board could expedite movement toward a total change in the system. So the Obama administration path of controlling costs is to cut the fat as much as possible out of the existing payment system and move thoughtfully and assertively in terms of changing the system so that we pay more effectively for health care and actually get a more efficient system. Now, will it work? I don't know. But it is a direction that I think is the right one on which to gamble relative to a system in which we are simply setting dollar amounts that send people shopping and gamble that they'll be okay. With the Romney proposal, all the risk is shifted to beneficiaries. With the Obama approach, all the risks continue to be held by the program and by the budget, and the responsibility remains that the purchaser getting value for the dollar in the program. Now, one final word. What I believe is that we are on a path for much slower growth in Medicare spending than it was the case per capita spending. then I can't do anything about those beneficiaries. I'm doing my part. We're coming. But it is if we want slower growth that is going to be achieved with these programs, what we need to do, we can't rely on the Medicare program alone. Medicare is slightly better than, as I've told you, private sector. This nation's problem with health care is all of health care costs. Not the government part, it's all of health care costs. And if we want to be more aggressive in the containment of costs, we can't be much more aggressive in Medicare without putting beneficiaries' access to care at risk. You can cut a lot, but at some point, if there's too much of a divergence between the public and private sector, Medicare becomes a welfare program, and people will have to find ways to ante up or not get care. So that is not a direction in which I want to see this program go. So it is not talked about a great deal. It has been historically, but we've never pursued it in this country. It is to do across the board controls on health care spending. Massachusetts has just enacted a law that moves in this direction. Maryland has something that controls all hospital rates. All payers pay in a similar way, and you can pay differential rates, but you pay on the same basis. That's the direction. When asked, and as I was by Congressman Ryan, what would I do to control the cost of the system, I told him I'd apply the Independent Payment Advisory Board lid on all of healthcare spending. And he thanked me for my candor, and he told me he appreciated it, and I thanked him for his appreciation, and I go on to challenge his approach, which in other words, in my view, lets us all hang as we go into the future. So that's my story. I'm sticking to it, and I'm happy to engage in any element of what I've raised or clarification or other issues that are on your minds. Thanks.
Yes, thank you, Doctor.
Please call me Judy. It's fine.
Thank you. Thank you, Judy.
I think she can hear you.
But she wants to be recorded, right? Yeah.
Yes, Judy, thank you. I'm Judith Henderson, retired Foreign Service. Back to the $716 billion, and you talked about the excessive payments. How was that amount projected? Was it projected on a horizontal basis in which there were certain costs that were established to be reasonable costs, and anything above that was lumped into the $716 billion? Or were there certain categories of health care service that were particularly egregiously expensive, notably MRIs and things like that?
Yeah, those are the good questions, and the way in which the $716 billion, the bulk of it comes from two different sources. One is reductions in rates of growth to payment to hospitals and skilled nursing facilities that provide that post-hospital care. And the reductions in payments to Medicare Advantage plans. And so the way in which the savings are achieved, there is a scheduled rate of increase in the law for payments to hospitals and nursing homes. And the way it is very easy to ratchet down if you so choose. And so that it's the productivity adjustment. The argument is that these institutions can be more productive, like every other institution and entity in the economy, and so they just took a cut off the top and slowed the rate of growth. The Medicare Advantage plans are, as I indicated to you, the payment, they too are paid on a kind of a formula basis, and that formula, which was established in 2003, modified somewhat in 2006, is overpaying relative traditional Medicare. It was done intentionally. It was part of the Medicare Modernization Act. It was done, which provided the drug benefit for the first plan, but was very focused. As you would think, it was a Republican proposal on getting private plans into Medicare, essentially looking to move Medicare away from a government program and to make the private plans attractive. So the plans were intentionally overpaid in order to give them resources, since they couldn't beat Medicare on its prices, but to have some extra revenues to give people the extra benefits, fill in some of Medicare's gaps, and attract beneficiaries into the program. And so what the way in which the savings are achieved is to pull back those overpayments. Now, for the most part, those plans have stayed in and continue to offer extra benefits. But that, we can talk more about whether that's the right way to provide extra benefits. But they've now become very engaged in this market, so it appears that Medicare doesn't have to pay them so much in order to keep them in. So that's where the savings come from. Okay?
Frank Miller. We paid into Medicare with payroll taxes. And those taxes were capped at a certain amount, which is about, what, 100?
Actually, Medicare taxes are, the payroll taxes are not capped. They're different from Social Security,
So-
and you pay them all the way up.
Oh, so we do pay them all the way?
Yeah, yeah.
Well, then that answered my question.
And actually, as part of the Affordable Care Act, we raised them. Right.
Nice.
Hi, my name is Craig Olson. I'm a retired Foreign Service officer. When my mother was in her early 80s, she went into long-term care.
In a nursing home?
Yeah,
Or-
nursing home, yeah. And so, you know, my brothers and my sister and I talked it over, and we said, you know, we looked at her finances and said, okay, you know, with the sale of the house and the Social Security and others, you know, she has enough money to last until X year,
Yeah,
right? That was almost 15 years ago.
wow,
Well, she's 95 now.
good for her.
About 3 years ago, she ran out of money.
Mhm.
So, you know, when we said, okay, well, we'll just have to, you know, siblings will all pitch in. But then the nursing home said, we'll take Medicaid.
Right,
So she is in fact living on Medicaid now.
Yeah.
Now, my question, this is a personal story, is, you know, about that time, I was retiring from the Foreign Service, right? And they were trying to get me to buy long-term
care insurance, yeah.
long-term health insurance.
Long-term care insurance.
What's it called?
Long-term care insurance.
Long-term care insurance, right. And I said,
Pay for it.
Medicaid will pay for it if I run out of money. Am I right or wrong?
You are right, but let me give you a little bit of perspective
Because
on it.
Medicare doesn't.
Medicare does not pay.
Yeah.
Medicare does not pay.
And neither does our.
Does our federal employee or even foreign service, whatever, doesn't, no, it doesn't. Long-term care, as I said, but I'll repeat it, long-term care is overwhelmingly provided by most people who need long-term care are living at home. There are about 10 million people who need long-term care. 40% of them, it may surprise you to know, are under the age of 65. They live, there are about 10 million, I said, and about 1 million live in nursing homes. People who can want to stay at home. Medicaid is designed as to be last resort care. It's there for you when, as you've described, when you've exhausted your resources. It is different from insurance because it doesn't protect you from financial catastrophe. It's only after you give everything up that you get Medicaid. There is, in my view, there is nothing wrong with relying on Medicaid as when you've exhausted your resources. One of the reasons that we have Medicaid to do this is to enable families to take care of their children, and at the same time that their older family members are taken care of. So it is regarded as one of the safety nets that we have. I'd like us to have a social insurance program for long-term care so that we're all paying in some way, and you don't have to be impoverished. People argue that that argue that it should be an individual responsibility and object to Medicaid, argue that the presence of Medicaid does deter people from purchase of private long-term care insurance. I suspect you're an exception in that regard. Private long-term care insurance is a pretty lousy product. And the evidence we have is that it is not, such as it is not that it's Medicaid that's keeping people from buying long-term care insurance. It's that it costs a lot. My general view is if it's pin money to you and you want to just, which is especially my mother's, but we're all the same age. So if it's nothing, just, and you want it and gamble on it, some people get good benefits out of it. But the industry itself has a problem in making that benefit work, and more companies are pulling back. We don't have the companies are pulling out of that business because it's different from health insurance in that they want people to buy when they're young, so that and stay with it. But then you're pricing a product for many years. Your mother being I mean, that's when she went in at 80, for heaven's sake. They want us to buy it at 50, at 40 and 50. And they're projecting what the cost will be. The way they do that is to limit the dollars, they limit the benefits that it will provide. They limit the rate of inflation so that if your mother had purchased that product when she was 50, she'd be getting bupkis out of that product today, right? So it's a very challenged product. They're supposed to do, the law requires that they, I think if they're approved policies, that they have to have rates that remain the same over the life of the policy. But what they can do if they run into trouble or they're looking to make some money is that they close down that product and now they offer a new product. So this old product is filled with with people who are getting older, and then they're allowed to, when they've got a problem, they're allowed to apply for an increase in rates. So you can pay in for many years, and then the rate hikes will happen, and if your resources are constrained, you may not, you'll lose it then. So it is a very limited, it doesn't work as a market. It works much less well than health insurance, and we know we've got problems in that regard. So I think that's unfortunate. That's not a solution. Medicaid, when the argument is so that people are giving all their resources to their children and doing things under the table, there's no question that happens. But when you look at the resources of most seniors, they don't have that much to give away. So that too is an exaggerated problem. And my own view is your only choice is not to have a safety net. And I mean, you've got these issues at the margin, but I think much more harm would be done if there was no safety net. One more point. I said most people want to stay at home. Although it's improved in recent years, Medicaid long-term care is very heavily focused on nursing homes. Still, most of the money goes in most states to nursing homes. Home care is expanding, but Medicaid, but nursing home care is the primary source. Most people would rather stay at home with home care.
Medicaid will pay?
Medicaid pays, it varies tremendously from state to state. It doesn't pay for it so well, and it depends on where you live.
I'm a retired Foreign Service officer, but I'm approaching Medicare aid, and I live in Arlington, Virginia.
Mm-hmm.
So I kind of want to play a bit of devil's advocate with you.
Sure.
You had said, first of all, that Medicare works because it's the big Megillah negotiating the rates for Medicare recipients.
Yeah.
And I'm from Wisconsin, where there are lots of people over 65, and where my brothers and sisters have a range of Medicare-affiliated doctors and hospitals because they live in Wisconsin. However, as I personally approach looking at Medicare opting in, my doctors, because I was here in Foggy Bottom, are mostly along K Street or in Washington, D.C., and they're not Medicare participants. And when I ask people who live in Arlington or areas like Arlington, you know, do they have doctors that take Medicare, because I would assumably have to opt into them, they say, well, only because I've been seeing them for 20 years, or no. Now, maybe I talked to the wrong people, but it would seem to me that it's possible that your overall Medicare works because it's the big Megillah, works in places with lots of elderly, but in places like this area, it does not work very good. But even if that is quasi-flawed, because I talked to the wrong people, the bigger picture part of my question is, if there is some truth in the difficulty in this area and finding appropriate providers once one is in Medicare, does not the focus on putting pressure on providers in future, as you described the current Democratic kind of approach, mean that more places could become more like Northern Virginia and less like Wisconsin?
Very, very well. Okay, so
Do you understand that?
I totally understand. I think you'll see if I miss something, but as I answer you, first of all, I want to say absolutely no such thing as talking to the wrong people. So if you have found that experience, you're talking about something real. What I would tell you is that when we look beyond, when the Medicare Payment Advisory Commission regularly does, which is different from the new one I was telling you about. This is an technical advisory panel that Congress has. They regularly survey on Medicare access, and they find that overall that Medicare beneficiaries are doing fine in terms of access. There are some areas where people are having, I had thought it would be specialty care. It seems not to be specialty care. It's primary care where some difficulties arise. I'll give you a tip. I live in McLean. I have a New Mexico Avenue physician who decided to go for, become a concierge physician. Have you been solicited? I was horrified. I really like this guy. And because what they're doing is saying, if you, boutique practices, if you pay us $1,300 up front, then we'll see you and and I can't do that. So, and talk to groups like this, that to me would be disgusting or wrong. And so what I did was look for, and then so this is the second time I've had to look for a new doctor, and a friend of mine who is a physician who got me that physician, sent me there in the first place, he said, we're getting old, we need to look for a young one. And you will find, I found in that very same practice, that the young docs, there are docs who are full and it's more likely to happen, and it's affluent urban areas. You are more likely to find that some are able to pick and choose, but you can find others. I'm happy to share with you the name of my physician. That's her. And he looks young enough to be with me for a long time. But again, I think that you want that the national. It doesn't mean it never happens. It's kind of like what I was saying about Medicaid and people giving away their money to their children so they qualify for Medicaid. It happens. But when you look at the aggregate picture, it is not happening. Now you're concerned, or it's not happening on a large scale. And in fact, when you look at access and ability to get appointments, the Commonwealth Fund does a lot of research, like this Medicare is doing as well, if not better than private insurance in terms of waiting time to see your doctor and that kind of thing. Okay. When you're talking about the future, you are completely right. If you constrain, that's what I was saying. If you keep a lid on Medicare and you take it too far, you will create access problems. You will divvy up people with money from people who don't have money, and you will limit access for a substantial part of the population. I don't think we're there with Medicare, but if we get there, if it looks like we're getting there, what I'm saying, we have a couple of choices. We can just keep paying what the private sector is paying, and then or what Ryan and Romney would do would be, if you can buy it, if you can pay extra, go be my guest. That's where they would go. Although they're throwing money back into the system and claiming that that's a good thing. These extra payments, they put them back. So what we need to do in this country is control all healthcare costs and do the same thing for everybody. That is my belief. It is not When you look internationally, it is not an outlandish proposal. In this country at this time, I'm having a little trouble selling it, but that's where you need to look.
I have two really quick questions as a follow-up to this gentleman on the long-term care and Medicaid. My brother's mother-in-law is in a nursing home in Western Pennsylvania where I live, and she'll be there until she dies. She has Alzheimer's. And my sister-in-law said, her daughter, that she has very little, so she's, in terms of savings, so she's exhausting it, and once that's exhausted, and I'm sure it's already exhausted, she will be there on Medicaid.
Right.
But my sister-in-law, who actually works in the hospital connected with this nursing home, so I think she's kind of informed pretty well, she's saying that, yes, that's the way it'll work, but if she ever wanted to change, which we don't foresee, but if she did ever want to change, that's the problem, that the next nursing home will not be taking that person in because they're on Medicaid. So that's my first question.
Okay.
Is what I just stated correct? And I'm interested also because I'm in the government's long-term health care, and I have been since they first offered it. And I have a very good plan, and I'm wondering if the reason I think that I did something right is because if I would ever have to get in one, I have retained my option, plus I've protected my savings, but I've protected my option of being able to change if I would ever have to change. Change nursing homes.
Okay.
And then second, very quickly, is because of this same lady, I'm concerned for her because the Romney plan, if I understand this correctly, they want Medicare, they say they're not going to touch until into the future, but they are saying that they're going to touch Medicaid immediately. So, and even President Clinton in his speech, if I'm not mistaken, said, what are you going to do with all these people who are currently depending on this? And then they've given, under Obamacare 2, the states are, Medicaid I think is going to go into block grants to the states. So what my question boiled down is how do you foresee Medicaid affecting people immediately if Romney gets elected?
Okay. Thank you. And let's start with the Medicaid beneficiaries' access to nursing homes, which was your first question. Unlike Medicare, which in most places, including here, most physicians will take, the access for Medicaid patients varies. And it varies probably not only across states, but in localities. The nursing homes, one of my very first research pieces in healthcare was looking at nursing homes. I was interviewing nursing homes about access for different kinds of patients, and I was asking about discrimination against Medicaid, and the administrator said to me, he said, "Let me be very clear. We don't discriminate by source of payment. We discriminate by amount of payment." And I laughed and I said, "I won't quote you on that." And he said, "You can tell anybody you want to at any time." So they get the most from private payers. They get next most from Medicare and that post-acute, and they typically get the least from Medicaid. And how bad it is varies from place to place. And homes they make their own decisions on what they're providing and what mix of patients. So it doesn't mean that no one will take Medicaid patients, but it means that it's harder to find a place that will take Medicaid. So that is an appropriate concern. When you ask about private long-term care insurance, your comment reminds me not to be flip when I said if it doesn't matter to you, buy it if it's not that expensive. The federal employees plan is a good plan, but it does in fact suffer. Right? If you bought it young, you bought it then at a lower rate, and they will try to keep it. It's not in any way a guarantee.
No, I already had the price increase once.
That's right.
Every 7 years they do a new owner.
That's right, and you don't know what will happen, but it was not, again, it was not a bad bet. I just don't think it's going to work for a lot of people as a systemic approach, and I am skeptical about the ability of those policies to come through to do badly. On your third question, you are quite right to raise that what the Ryan Romney budget would do to Medicaid, which is eviscerated. And the Ryan proposal was essentially talking about taking $750 billion out of Medicaid spending for current beneficiaries. I've sung Medicare's praises on efficiency. Medicaid is the primary purchaser of nursing home care, but it pays on the margin for everything else. It pays peanuts relative to what other payers have. So it's not going to pay less. We have no evidence that Medicaid beneficiaries are overusing services, and so when you constrain it, what you're going to do is get less. And the reason Medicaid is growing, I was at a meeting last week where Medicaid costs, and they're driving up the budget. And you look. I can refer you to sources if you'd like them. But Medicaid, just as I told you, Medicare is growing in large part because of the baby boom generation. Medicaid is growing because we have too many poor people, and because poverty is growing, and that's who's coming in onto the rolls. And these cuts have nothing to do with the expansion of the Affordable Care Act. This is out of existing Medicaid. So there is a study done by my colleagues at the Urban Institute that looks at hypotheticals, because states get to choose where to cut, but it means people won't have health insurance, people won't have long-term care services. That's what it means, and that is a correct statement. Now, the Obama administration, those are block grants, essentially block grants. Instead of having spending for state spending on Medicaid, the dollars that states spend are matched by the federal government. They're open-ended matching grants, that match what poorer states get higher match. Very varied from state to state. Some states, no matter, even if you're giving them 80 cents on the dollar, it's not enough to make them spend. So richer states spend more than poorer states. But it is an open-ended grant. It's an entitlement. Everybody eligible, or it's hanging on by a thread in terms of whether you can go to court to get it. But in terms of the mandatory spending, the spending goes with how many people show up and what the care costs. And the proposal is to turn it into a block grant, which would cap the amount that the states get. Governors have for years wanted the federal government to at least take over responsibility for what are called dual eligibles. That is the elderly Medicare beneficiaries who are also eligible for Medicaid. That's poor elderly and disabled people. They've wanted them to take over, but now, since the feds won't take them over, they're saying, well, just give us the money and we'll be, okay, we'll manage. Well, they won't manage, and they will manage worse as the population's continuing to age. So very bad policy. Sad to say, the Obama administration is not proposing that. But the Obama administration is proposing, is soliciting proposals from states and negotiating with states, pushing states encouraging states to put dual eligibles, people who there are all kinds, there are healthy, just poor healthy people, still healthy, but also this long-term care and young disabled population, into managed care plans. And essentially put Medicare money in and Medicaid money in and let the plan manage care. Well, there is almost zero experience in managing care for highly disabled populations. And this is taking a cut off the top, and I would argue that this is a budgetary policy. It's selling poor old people under the bus, throwing them under the bus, and I'm doing what I can to slow that policy down as well.
My name is Kurt Tyre. I'm a retired foreign service officer. My problem is not with Medicare. However, I've been approached by quite a few number of overseas American citizens, retired overseas, non-foreign service, non-federal government, but they get no payment from Medicare for medical expenses incurred overseas. They have to come back to the United States, or you can't always do that. I mean, if you're serious here, you're not going to jump on a plane just because you want to go to the hospital here and have Medicare pay for your bills. My question to you is, one other thing. When I was overseas, and I submitted to Blue Cross here in Virginia and to GEHA, I don't know where, Wisconsin someplace, my overseas bills for reimbursement, they told me, you're welcome, come send us more. It's so cheap compared to what we'd have to pay for your same medical expenses here in the United States. We have no objection for Medicare paying overseas claims. Why don't we?
I was afraid you were going to ask me that question, to which I don't know the answer. I know that you're right. And if you could, Bonnie can put me in touch. I don't know what the argument is to why that's not been done.
Sometimes they've said, I've talked to these people, and sometimes they have too much administrative problems. We can't translate the doctor's diagnosis and
it sounds like baloney.
And then we have the currency. But
yeah, they could do something.
Says, no problem.
Yeah.
Tell them to shut up. We can save so much money.
It's also, I had not had an experience till recently, a couple of years ago, traveling. I was in Germany, and my husband was sick, and we needed to see a doctor. This is not about Medicare at all.
Yeah.
It is embarrassing. It is embarrassing how readily you are taken care of with how, and I thought if that had happened to somebody and it was cost nothing, wasn't fancy, and fortunately nothing was wrong with him, but if you'd had a friend come from Germany come here and need something, they'd have spent the entire day in the emergency room, and it would have cost them an arm and a leg. Hopefully not literally. So it just is embarrassing. But if you're in touch, I'll see what I can do in terms to get you at least what the rationale, the best I can do on the rationale.
I think there are 2 million overseas Americans who are not retired federal employees, and they during their working days
They contributed. They contributed. No,
nothing.
Yeah.
And when they come back to the States, if they finally do move to the States and they want to enlist Medicare and the supplementary program,
they have to pay.
Fine.
Yeah.
Well, if they had paid, if they had signed up when they were 65, they would have been paying premiums for insurance
that they couldn't
coverage.
use. I hear you, and I hear your outrage. I'll see what I can find out about.
Thank you.
At least what's a plausible, if there is a plausible explanation.
My name is Paul Emer. I'm also a retired Foreign Service officer. I don't know there was an article in the New Yorker a month or so ago, 6 weeks or so ago, written by a doctor, I believe in New York, Pennsylvania somewhere, and it was very interesting because the article was about our healthcare system as composed to the Cheesecake Factory.
I think I haven't read it. Was it Tulugawandi probably who writes for the New Yorker, right? Yeah, yeah. And he's a Boston surgeon.
He's from Massachusetts.
Right, who was Clinton's health advisor in the first Clinton campaign.
I don't know who the guy was, but it was actually a very nice article, and it brought to mind a question that I had that I wanted to ask you, which is, we used to have things that were called health maintenance organizations, HMOs. I guess we still have.
We still do.
I live on the West Coast, Group Health, Kaiser, and so forth. What I don't hear is anything talking about those entities, because it sounds very much like what you're saying, that they're trying to push everybody toward managing care properly, getting good quality, doing efficiency. Isn't that what a health maintenance organization
You picked it right up. That's right.
And why isn't there more talk about pushing forward the group healths and the Kaisers that have been actually successful in that? But then going back to this doctor's thing, Cheesecake Factory and our healthcare system. I mean, what he's saying is the Cheesecake Factory, I forgot the statistics, but the Cheesecake Factory loses 0.01% of their food because they have a computer system that tells them how much food is going to be used and how many people are going to eat it and all that. And why can't we have our...
They're just so efficiently managed, is what he's saying.
They manage things efficiently. Why can't we manage our healthcare system?
Yeah. He's very good. If you look at, he did a couple of pieces during the Affordable Care Act. There's one on experimentation, like the pilots that I'm talking about, and that he compares to the Agricultural Service. You might find that one interesting. And there's another one in which the president used a lot, I think called attention to at one point. It's on, like, why am I not remembering the name of the town in Texas? It's not Allentown, that's Pennsylvania. But there's McAllen, thank you, McAllen, Texas. It gives you I use it when teaching my public policy program to explain what's driving up costs. So you'll find it. So I think what the short answer on why we don't do it is, hey, you pay them to be not, you pay them when they're not efficient, why the hell would they be efficient? So the payment system, I mean, again, even before I did this study on the nursing home thing, when I did my dissertation, it was on the design, the politics of the way in which payment systems were designed, and they just are designed when you pay costs. As you would know from long ago when we talked about the Defense Department and the whatever, however expensive that toilet seat was. Thank you. You go, we all remember that. So it is essentially, we've never paid them on a basis that would encourage efficiency. It encourages spending. And when they did it at the beginning, it was a desire to get everybody to participate as the Medicare program was being launched. And it was also, there was no such thing as too much health care. There's not, I guess, no such thing as too much defense, even when it's toilet seats. So so it requires, that's where we're trying to move. Now, on your question on HMOs, you went right where you ought to go, which is this language on, they're now, we call them accountable care organizations, a newly coined term. HMOs or health maintenance organizations, they used to be group health organizations or prepaid group practices. And health maintenance organization was coined in the Nixon administration, in the Reagan administration. I'm one of those guys. Okay, and it was, I think it was Reagan administration. And it was, and you could hear what just like health maintenance will pay you to keep people healthy, accountable care will be accountable for care. So it's and the argument is that you give them a bundled payment, one payment, and then they make money if they keep you healthy. The problem with the incentives of that, I would just tell you, when accountable care organizations are moving more gently, the problem is we have a problem now, and then if we pay on a fee-for-service basis, the more then you're rewarded, the more you give, the more you do, the more you get. Okay, that's too much. When you flip the incentive all the way, it's not necessarily efficiency; it's too little. Okay, you're counting on norms, and there's all this risk selection and bad care. It's not efficiency; it's just a different incentive. Most of HMOs were private insurance companies that didn't do anything. I mean, in fact, the biggest effect, if you remember in the 90s, there was a very big when all of a sudden employers moved aggressively to move people work-based insurance into HMOs. And there was a big outcry. Somebody's going to remember the name of the movie with Helen Hunt, where she made a complaint about, and I think, who was it with? Was it Jack Nicholson? Yeah. Pardon me? As good as it gets. Right, and she complained about her HMO, and all the in all theaters, everybody was clapping. And so they pulled back some of the restrictions that they were exercising. The evidence is that the way in which they generated savings was not so much on restricting utilization, which is what people were reacting to, putting barriers between you and the doc. But it was they began to pay more attention and constrain what they were paying providers a bit more the way Medicare does. So we never saw them do very well. When you pick out a few, you pick out Kaiser. Geisinger is pointed to. Mayo is pointed to. And probably even more than Kaiser, Mayo and Geisinger are integrated systems in which they do talk to each other, and they have mechanisms, whether it's Cheesecake Factory-like or not, there are mechanisms to really efficiently manage the delivery of care. And the goal is to try to replicate those. The challenge in replicating those is that most physicians still practice in very small practices. Now so the new programs, the accountable care organizations, are trying to entice groups to come together. And instead of doing it on a straight per capitation basis, where they get to keep all the savings, which is probably the most effective, they're trying to do shared savings. So some shared savings, shared risk, and you can think of it as a continuum. You want to give them enough money so that they do good, but not so much that they go to rock bottom. And they're also trying to put more emphasis on quality standards, but we don't have them yet. So that's where we're trying. And this time, although we've tried this before to no avail, this time we're trying to do it with the docs and with the providers themselves, without the insurance company in the middle. But ultimately, I will tell you that it is an organizational structure. We're coming at it in a different way, with more accountability, more gently. We don't know where that's going. So that really is the direction. You've nailed it.
Do you have time for more questions?
I just have to watch my meter, and I am fine. Okay, yes.
Miller Patch, I'm a retired.
And anybody who wants to leave, I won't be, I'll be sad, but I won't be offended. Okay, fine. It's been a pleasure. Go ahead.
Could you prognosticate a bit from a 30,000-foot level as to the restructuring that either the president's plan, if it goes forward, or Governor Romney's plan, if he wins the election and there's a change and then he's in the driver's seat, will be on the hospital industry and on the physicians in private practice?
Yeah.
Because it seems that there is already an effort by the hospitals to consolidate
Yes.
private practice
Yes.
into and under them. And
Yes.
I actually read some articles where this has, so far anyway, been shown to increase costs.
You are completely correct, and I'm really glad you raised it, because it was where I wanted to go, and I was trying to remember where I wanted to go is exactly where I wanted to go with respect to your question. The easiest, as providers are encouraged to come together into groups, it is easiest for hospitals because they've got the most capital and the capacity to build systems, and they are reportedly increasingly hiring physicians. And while ultimately it might not be a terrible thing for physicians to work on salary, if hospitals have considerable market power, and in many communities they do, then essentially what you've seen, the evidence that I've seen comes from California. The hospital negotiating on behalf of the physician actually increases rates. You know, they may be able to deliver care more efficiently, but they become able to charge whatever they jolly well please, because everybody wants to go to that hospital. So I think it is quite possible that there will be more consolidation, and that's a problem. And some have suggested more aggressive legal action. I'm not sure that it's quite antitrust, but something of that ilk to watch against excessive concentration. But at some places it's too late for that. And where that takes you is back to what I was talking about in terms of not just public payers constraining costs, but public and private payers actually negotiating really with providers in setting rates, so that it comes to more of you've got to match the private power with the public power to negotiate payment rates. And if the industry is highly concentrated, it does seem to me that is where we would have to go.
Dick Thompson, retired Foreign Service. This is really a comment more than a question. The lady was talking about not finding doctors who took Medicare in Northern Virginia. But a few years ago, my primary care physician was very good. Went off of Medicare, and he was so good I stuck with him. But it really doesn't matter. I pay him a few $100s a year for a medical exam and maybe a couple of office visits. But everybody specialists he refers me to all take Medicare. So I think if you have a good doctor, it doesn't matter all that much whether your primary care physician, usually an internist type of thing,
Interesting.
whether he takes Medicare or not, because your
You're
big
saying
expenses will be covered.
You're saying you can manage that out of pocket, is what you manage it out of pocket. You manage it directly.
It's just a few $100s a year,
Interesting.
and for a really excellent doctor. So I think it's well worth it.
Interesting.
Sticking with him, and as I say, the specialists are all take Medicare.
Good to know. So you've got that option as well.
Well, actually, my personal doctor, when he refers me to someone, is almost always someone who doesn't process any insurance claims at all.
But there's a difference between that.
So right now, I'm paying when you talk about the managed rates, as you know, most insurances have a preferred provider
That's
network.
right. Okay.
So they're already doing that. They're already negotiating. They're already saying, if you see a doctor and it's one of our doctors, then we'll pay $175 because that doctor will forgive $25 and we'll pay him $175. But when you go to a non-preferred provider,
Right.
then your insurance company agrees to pay X or Y that is less than what they essentially are paying their preferred provider. And so you're actually paying, say, 50% of that doctor's, as opposed to 70%.
And what it,
And
yeah.
I think the world of my doctor, but he doesn't process insurance claims, and he refers me to fantastic doctors throughout the Washington area, and none of them take insurance. So I think you're fortunate.
Well, let me make a distinction, because there's a difference between not processing your insurance claims and not accepting Medicare.
But they're both.
Okay, so, but because not, I mean, there are a lot of docs who won't do the claim, or I think there are a lot who won't do the claims, but the situation that this gentleman is describing, if he really won't take Medicare, won't abide by its rules and his rates, then you are not allowed to receive Medicare reimbursement for, nobody gets paid through Medicare. So that doesn't happen a lot because most people can't do that, and most practices can't do that. The point you're making about networks is one of the challenges in choosing an insurance plan, which takes us back to the whole idea of going shopping, is that you don't know what's in that network. It's very hard to know whether the docs that you want are going to be in particular networks. And a plan can have a very narrow network so that any doctor that you'd really want to see is going to be out of network, and you're not getting much coverage on. So that's another significant challenge in terms of the nature of the healthcare system.
Hi, I'm Lee Roussel. I'm a retired Foreign Service Officer. And I want to start, Judy, by thanking you for making so clear a very complex subject.
Thank you.
But I'd like to return back to the selfish concerns of retired Foreign Service officers. It's not clear to me at all whether I should be signing up for Medigap insurance. I have Blue Cross. I've been told that the drug benefit under Blue Cross Federal is as good as the Medigap drug coverage. But what about the other services? You mentioned one reason, which is that you could get into a ceiling situation where you could have unlimited out-of-pockets, and that might be a reason.
So do you have Medicare as well as Foreign Service insurance?
No, I have Part A only.
Part A, we were discussing that earlier. I think that's fine. I think that, I have federal employees. My husband is a retiree, a CIA retiree. It seems to me it's pretty good coverage. And that acts as it's acting as both your Part B and your Medigap. So I would say, based on my experience, I'd have to know more about your details, your specifics, but I think you're just fine. I don't think you need another product.
There's an article in Consumer Checkbook that goes over all of that. And basically, they agreed with your decision, which was to take Medicare A, not take Medicare B, and stay with the federal health insurance.
The reason, as we discussed, a reason just for everybody's information, a reason that, and I think it's unfortunate because I told you we're pooling risk, and what are we talking about? Getting out of the pool. That's not good. The reason for that is that Medicare now charges an income-related premium. And so if your income if you're better off, then you're having to pay a lot for Part B. When you could already get it, you can keep it as a retiree. Now, we are in a privileged situation in that most retirement coverage is going away. I'm counting on U.S. government status retirees holding on to ours. But and members of Congress have what we've got, so that's a good tie there, good protection. But that does make us different from most retirees because those benefits are going away. So because you'd have to pay a substantially higher premium than used to be the case to get Part B, what you get, as I understand it, if you pay it, you'll have double coverage. You won't have holes. You'll have you've got your out-of-pocket cap. You're okay.
My name is Margaret Eubank. I'm a retired Foreign Service officer. I'm really kind of interested in the relationship between Medicare and the supplemental insurance.
Same, yeah.
And actually, I just recently had a hip replacement, and Medicare for outpatient they had caps for physical therapy. And so the place where I go, they will accept the Medicare caps. But I'm kind of at the second cap now. And so they said to me, well, if you want to continue, then you have to pay. We'll still submit it to Medicare, and Medicare will say we reached it. And then the supplemental, if they pay you, then you'll get reimbursed. But they were telling me that several supplementals are saying that they're not reimbursing, even though in their policies, maybe you get 100 treatments if you were not under Medicare. And I just wondered if that's kind of a trend. This is just one example that I experienced. And the other thing I noticed is, just as there seems to be groupings of hospitals and all, it seems to me that that may be happening with the supplemental insurance too. We have Coventry as our supplemental, and now they've been bought out by Aetna. And so I wondered...
Consolidation of the insurers,
so one
yeah.
is kind of a particular question, and the other is more kind of a general one as far as what is the direction of supplemental insurance in relation to Medicare?
You hit me on the therapy caps. I am sorry, it's another one that you hit that I don't know enough to answer your question about, to explain the therapy caps and their legitimacy. What I would say is that, because I think there are concerns about them and whether it is simply a fiscal limitation that is stopping short of needed care. In terms of whether the supplemental, the Medigap policies are covering more, I would imagine that varies with the Medigap policy. And I don't think one can count on it. It's, again, one of those things that in your specific circumstances you need to know the best you can what they will do. The same among the Medicare, other things that people, and I'm telling you that they're getting more constrained, but people go to Medicare Advantage plans, which are different from a Medicare supplemental plan. They are, not all of them are HMOs, but a lot of them, the better ones are HMOs. And they get well paid from Medicare, so that's another way. You get all your benefits then through that private plan. You'd get your traditional, your Part A benefits and Part B benefits, and the extra benefits would come from one plan. And you might want to look into whether that, although you're standing tall and it looks like you're going to be fine, you'll have to look at some other problem that we don't know whether it's going to work for you. But the supplemental benefits, I think, have always been somewhat problematic and hard to predict, and I think the best I can advise you is to look for recommended plans and see what you can do to find out about specific conditions. On insurance consolidation, that too has been, the insurance industry is highly concentrated, and I can't give you chapter and verse on it. Whether it's becoming more so in the last couple of years, we're seeing actually, which is not related to your problem, but I have your question, but it's interesting. We're seeing that in recent, in the last year or so, or since the passage of the Affordable Care Act, major insurers are buying up Medicaid insurers, because Medicaid, for its non-elderly and disabled population, for its moms and kids, has been relying on managed care for a long time. And the plans that are selling to Medicaid beneficiaries are being bought up by Aetna and WellPoint, or United, I've forgotten who recently bought them, which looks as though they're betting on the Medicaid expansions of the Affordable Care Act going forward, and they're looking for that business. But that was just an interesting factoid, and I think that your belief that things are getting more concentrated is, we already find that in most states that there are fewer than a handful of major insurers. So it is already a very concentrated industry.
I'm Donna Sandon. I'm a civil service retiree, but I'm getting the Foreign Service protection. My husband was a Foreign Service officer. Anyway, we've had no problem. As soon as I became eligible for Medicare,
and then Medicare became primary. I was just astounded, and I'm still shocked, how little the providers get compared to what they bill. Because when we get the claim receipt from the AFSPA, we see it. You know, like they bill $250 and they get $25. I don't see how this is. I was glad to hear you say that they don't want to give us up because they can't afford.
I think that unless it's a situation where we're talking about going out of network, where you're getting billed for some difference, it is probably all nonsense. What you're looking at, I think, is it probably has no tie to what the service cost was. So please don't waste any time feeling sorry for them.
I'm paying absolutely nothing. I just had my...
Yeah, so I think the bills, I mean, for a long time, I mean, I remember years ago, my mother and my aunt were living together, and I don't know if you are Medicare beneficiaries, you get an explanation of benefits, and it says this is not a bill, and my mother was quite ill, and so my aunt, every single time, she paid it, and she was running a surplus at the hospital, and I don't know, I'm confident she's not the only person who did that, and I'm not at all sure what happens to that money. So I don't think the bills make any sense. And now the network stuff's another story, because they really do pay pittance relative to a charge and then stick you with the difference. That's a different story.
The other thing was that 20 years ago when I was in my 50s, I did buy long-term care that was offered by AFSPA. And then I got another one about 10 years later to go with it. So
You're protected. May you never use it. That's, there is something that we forget about insurance, and happens in, you hear it in hearings on Capitol Hill, and it's like a bad joke. And they say, oh, I'm paying for that insurance. I'm paying more for that insurance than anything I got out of it. And you think, yes, yes, that's what insurance is supposed to be about. So I hope that works for you. Thank you. Thank you.
I just ask you one more question about the cap, because I got confused about that. You said Medicare does or doesn't have a cap on.
In the Affordable Care Act, they established a cap that says when Medicare grows more than faster per capita, I think it's GDP plus 1%, that then this independent payment advisory board is authorized to make recommendations that are fast-tracked through the Congress, so have a bias in favor of passage. That reduce it, not the whole, doesn't have to bring it back to that level, but has to make cuts.
No, but I was looking at a cap as if I have a certain cost based on a sickness.
No, we're talking about those. They have what the lady was talking about. There are caps on therapy benefits, on the number of therapy visits, I think it is, that you can have.
Under Medicare.
Physical, in skilled nursing facilities. Or post.
But there isn't a cap on other stuff.
No, no.
Your doctor's name?
Yes, John Dooley. John Dooley is my doctor's name.
And
Foxhall internists.
thank you so much.
Oh, it's really a pleasure. Thank you, Mommy.